welcome to the deep dive. Today we're tackling a really interesting and often quite hidden condition, congenital absence of the inferior vena cava. We'll call it AIVC for short.
And our guide for this is going to be the big book, Rutherford's Vascular Surgery and Endovascular Therapy. Some solid chapters in there.
Right. So our mission today is to kind of unpack this unusual situation. We're talking about a major vein that just doesn't develop right during pregnancy.
Yeah, and figure out its surprising link to deep vein thrombosis, DVT, and then, how it's spotted and what doctors actually do about it.
And the really weird part, I think, is that loads of people have this and just never know. It pops up kind of unexpectedly when they're looking into why someone, especially someone young, got a DVT.
Exactly. It's a bit of a medical puzzle sometimes.
Okay, so let's dive in. What exactly is AIVC?
Okay, so basically, AIVC means the inferior vena cava. That's the huge vein carrying blood from your lower body back up to the heart. It's either completely missing or it just didn't form properly way back when you were an embryo.
Huh. How common is that?
It's pretty rare in the grand scheme of things. Estimates are maybe 0.3% to 0.5% of the general population, so not many.
Okay, 0.3 to 0.5%. Still, why the focus if it's that uncommon overall?
Well, here's the kicker. While it's rare generally, it pops up much more often when you look specifically at younger people who get a DVT for no clear reason.
Ah, okay.
We're talking maybe up to 5% of people under 30 who have what doctors call an idiopathic DVT, meaning they don't know the cause.
5% in that group. Well, that's actually quite a bit higher.
It really is. And, some early work like by Rogeri and his team back in 2001, they started pointing this out.
Okay.
They noticed there weren't many reported cases of DVT with AIVC, but they figured maybe it's because the usual scans don't always look closely at the big veins in the abdomen, so cases could easily be missed.
So many people might just have it and never find out.
Exactly. The vast majority probably live their whole lives with no issues, completely unaware.
Okay, so the missing vein itself isn't always the problem. It's this DVT connection that brings it to light.
Precisely. That link, especially noted in young men, is the key clinical relevance for many. The idea is that AIVC might create sort of a low-flow situation in the legs.
Right, like a bottleneck in the plumbing system. Slows everything down.
Exactly like that. And slower blood flow, well, that makes clots, DVTs, more likely to form.
Makes sense.
And then if you layer on top of that other risk factors someone might have, like inherited clotting disorders, things like factor V Leiden or hyperhomocystinemia.
Ah, so those could amplify the risk.
Yeah, definitely push it higher. It seems like it's often not just one thing.
A combination of factors then.
Looks that way. There was a study, Halprin et al., looking at kids and teenagers. It suggested AIVC might need a second hit, some other trigger to actually cause a DVT.
A second hit.
Yeah, which fits the general idea that most DVTs aren't caused by just one single thing anyway. It's usually multifactorial.
So what kind of second hits are we talking about? What could trigger it?
Could be lots of things. Maybe really strenuous exercise, growth spurts, those underlying clotting tendencies we mentioned.
Okay.
Or things like being immobile for a long time, having surgery or major trauma, cancer, having lines or catheters put in veins, smoking, even taking birth control pills.
Wow, quite a list. But you mentioned the body tries to compensate with collateral veins.
Absolutely. The body is amazing at finding workarounds. It develops these extra venous pathways, the collaterals, to get blood back to the heart.
Like detours on a highway.
Perfect analogy. And often these work really well, but they might get overwhelmed if the demand for venous drainage suddenly increases, like with those triggers we just listed.
Got it. So just to loop back, if you're, say, under 40 and you get a DVT out of the blue, AIVC is something that should be on the radar.
Definitely. Especially if it's unprovoked or if it's a really extensive clot affecting both legs, maybe in the iliac and femoral veins.
Right.
Or even if you see visible varicose veins on the abdomen, that can be a sign. Those collaterals are really working overtime.
Fascinating stuff. Okay, let's switch gears a bit. How does this even happen? Like the embryology behind it.
Right, the origins. Well, the IVC development it's complex, starts around week 6 of embryonic life. Imagine it like several pairs of primitive veins trying to merge and regress in just the right way.
Sounds delicate.
It really is. You have these 3 pairs, the supracardinal, subcardinal, and postcardinal veins. They connect, parts disappear, parts fuse. all to form that single main IVC channel.
Okay.
And the final IVC actually has different segments: hepatic, prerenal, renal, postrenal, each coming from different bits of those primitive veins.
So if something goes wrong in that complex dance.
Exactly. A disruption, maybe an insult during development in the womb, could potentially lead to AIVC or one of its variations.
Are there different types, anatomically speaking?
Oh, yeah. Several variations exist. Sometimes the IVC forms on the left side instead of the right. Sometimes you get a double IVC.
Double. Wow.
Yeah. Or you can have just a segment missing, or the whole thing below the kidneys missing. That's atresia or agenesis. And another one is where the blood flow detours up through veins in the chest, the zygos or hemiazygos system. It all depends on which primitive parts stuck around or disappeared incorrectly.
Okay, so that explains the how. Now, how do doctors actually figure this out? Diagnosis.
Well, first step is suspicion, like we said, young patient, surprise DVT.
Right.
Often the first test is a duplex ultrasound of the legs and pelvis. The sonographer looks for direct signs like, hey, I just can't see the iliac vein or the IVC where it should be.
Okay.
Or they look for indirect clues, things that suggest a blockage higher up.
Like what kind of clues?
Things like blood flowing backwards, reflux in the surface veins, seeing those big abdominal wall collaterals, or maybe the blood flow in the leg veins doesn't change much when the patient breathes. Normally it does. That's called respiratory physicity.
But ultrasound isn't perfect.
No, definitely not. It can be tricky depending on the patient's size, if there's bowel gas in the way, and it really depends on the skill of the person doing the scan.
So if the ultrasound is suspicious, what's next? More detailed pictures.
Usually, yes. You need what's called axial imaging to really map things out. That typically means either a CT scan with contrast focused on the veins of CTV, or an MRI scan focused on the veins in MRV.
CTV or MRV?
Okay. They give a much better picture of the anatomy and show exactly where the DVT is and how extensive it is.
Are there pros and cons to each, CT versus MRI?
Definitely. CTV, the CT scan, is fast, it's widely available. It's often better if someone has metal implants and maybe better for looking at stents.
Okay.
But the downsides are the radiation exposure, and the contrast dye used can potentially harm the kidneys, especially if kidney function isn't great to begin with. Plus, contrast allergies can be an issue.
Right. And the MRV?
MRV uses magnets, so no radiation. That's a big plus. The contrast agent used, gadolinium, tends to hang around in the veins a bit longer, which can give a really good look at the whole system, including collaterals. You can even do time-resolved imaging to see flow patterns.
Sounds useful.
It can be. And sometimes it gives clues about how old the clot is. But MRG has its own issues. Big one is certain metal implants, like pacemakers, are a no-go.
Right.
And the gadolinium contrast carries a very small risk of a serious condition called NSF in people with bad kidney disease. Also, sometimes the images without contrast aren't super clear, and MRV can occasionally make narrowings look worse than they are.
And then there's the old school method, venography.
Yeah, the invasive one, venography, where they inject dye directly into the veins and take x-rays. It's still considered the gold standard for visualizing the veins in real time.
So still used sometimes.
Oh yeah, often alongside the CT or MRI or maybe during a treatment procedure. It lets doctors see the flow directly, map out collaterals. Sometimes they have to guide catheters into specific veins. And they might use IVUS2 intravascular ultrasound. That's a tiny ultrasound probe on a catheter that goes inside the vein. Gives amazing detail of the vessel wall, helps confirm anatomy, measure things accurately, and check how well a treatment worked.
Okay, super helpful overview of diagnosis. So let's say AIVC is confirmed, often because of a DVT. What's the management plan?
Well, an interesting point first, the risk of a pulmonary embolism, a clot traveling to the lungs, is actually thought to be lower with AIVC-related DVT.
Oh, really? Why is that?
Because that main highway, the IVC, is missing or blocked. So there's less direct route for a big clot to shoot up to the lungs. But those collaterals can still provide a pathway, so the risk isn't zero.
Gotcha. So treatment is more focused on the leg symptoms then?
Primarily, yes. Managing the swelling, pain, preventing long-term damage in the leg.
So what does that usually involve?
Okay, so for an acute DVT, but with relatively mild symptoms, the standard approach is anticoagulation blood thinners.
Like warfarin or the newer ones?
Oh, exactly. Warfarin, low molecular weight heparin injections, or the DOACs, the direct oral anticoagulants. And because the AIVC is a permanent anatomical thing, that anticoagulation is often recommended lifelong.
Lifelong, wow.
Yeah, to prevent future clots. Plus, graduated compression stockings are usually recommended. They might not totally prevent long-term problems like post-thrombotic syndrome, but they can certainly help manage the symptoms.
What if the symptoms are more severe, though? or if it's a really big clot.
Right. Then the discussion shifts towards potentially more invasive options, especially for clots in the big iliofemoral veins.
The ones higher up in the groin and thigh.
Exactly. Options there include things like catheter-directed thrombolysis using clot-busting drugs delivered right to the clot.
Okay.
Pharmacomechanical thrombectomy, which uses devices plus drugs to break up and suck out the clot, or percutaneous mechanical thrombectomy, which is mostly device-based removal.
And these are for more severe cases.
Generally, yes, especially if there's significant leg swelling, pain, signs that the circulation is really compromised. Pharmacomechanical thrombectomy is often favored because it can clear the clot out relatively quickly. These are usually best done soon after the DVT forms, like within the first couple of weeks.
Is open surgery ever an option?
It is, though, less common now with the endovascular tools. Open venous thrombectomy, surgically removing the clot, is still a possibility in certain situations.
Okay. What about the long term? If someone develops chronic problems like severe swelling or ulcers?
Yeah, chronic venous insufficiency. If that happens, first step is usually imaging again, venography, maybe with IVUS to make sure those main iliofemoral veins are actually open.
Okay.
If there's blockage or narrowing lower down in the leg, maybe angioplasty could be considered. But putting stents in the iliofemoral veins themselves when someone has AIVC, that's tricky.
Why tricky?
Because the blood flow dynamics are already abnormal without the IVC, stents in that situation have a pretty high risk of clotting off again.
Ah, okay. So not always a great fix there.
Not usually the first choice, no. For really severe chronic symptoms, if the lower veins are okay, the last resort might be complex reconstruction, either open surgery, maybe using the patient's own vein tissue to bypass the blockage.
Trying to build a new pathway?
Essentially, yeah. Using their own tissue might avoid needing lifelong anticoagulation, which is a plus. Or there are some newer, highly specialized endovascular techniques like trying to stent open large collateral veins or even create a neocava using stents. But that's pretty cutting-edge stuff.
Sounds like there's still a lot of debate about the best way to go, especially with those invasive treatments for acute DVT.
Absolutely. The evidence isn't totally clear-cut. You have studies like CAVIN2, which showed that using catheter-directed lysis for acute iliofemoral DVT seemed to lead to better vein patency and less post-thrombotic syndrome 5 years down the line compared to just anticoagulation.
Oh, that supported the intervention.
It did. And a Cochrane review also leaned towards lysis helping with patency and reducing post-thrombotic syndrome. But then you have the big ATTRACT trial. That one looks specifically at pharmacomechanical thrombectomy plus standard treatment versus just standard treatment.
And what did ATTRACT find?
It found that the group getting the intervention had more bleeding complications. And while there was maybe a slight reduction in moderate to severe post-thrombotic syndrome at 2 years, it wasn't statistically significant for the overall rate of post-thrombotic syndrome. Quality of life wasn't significantly different either.
So NASIC was less enthusiastic about the intervention.
Pretty much. Their conclusion was that, overall, adding the pharmacomechanical thrombectomy didn't reduce the risk of post-thrombotic syndrome, but did increase the bleeding risk.
So it really highlights the need to weigh things up for each person.
Exactly. That bleeding risk with clot busters, it's real, maybe 5–10%. So you have to carefully consider the potential benefits, faster symptom relief, maybe lower long-term issues against that risk. Especially if the initial symptoms aren't that severe, treatment has to be individualized.
Okay. This has been, definitely a deep dive. Let's try and sum up the key takeaways for everyone listening.
Sure. So AIVC, congenital absence of the inferior vena cava, it's rare, often totally silent.
Right.
But it can unexpectedly show up as the underlying cause of a DVT, especially in younger folks without other obvious risk factors.
And finding it takes suspicion. And then usually advanced imaging like CTV or MRV.
Exactly. And managing the DVT when AIVC is present is complex. Anticoagulation is key, often lifelong. The role of more invasive clot removal treatments is still debated, with studies showing mixed results regarding long-term benefits versus bleeding risks.
And just thinking about it, it's pretty amazing that the body can often just cope with missing such a major vessel from birth.
It really is. Those collateral networks that develop, it's a fantastic example of the body's resilience and ability to adapt,
Definitely. It kind of makes you wonder, doesn't it?
Yeah.
What other systems that we think are absolutely critical might have these hidden backups, these redundancies we're only just starting to understand?
It's a great point. This whole condition really underlines why doctors need to sometimes think outside the box, consider rare things when something doesn't quite add up. And it shows how medicine is always evolving, always learning more about treatment.
Absolutely. Well, thanks for walking us through that fascinating condition, and thanks to you for joining us on the deep dive.